First of all, I would like to thank the organizer of this meeting for their kind invitation. I will try to talk about covered stents and its role in the recovery of vascular access. Angioplasty has become the standard treatment for venous stenosis in both fistula and grafts. Several reports of success and even the KDOQI guidelines recommend angioplasty as the first choice of treatment. At the present time, there are 3 generally accepted indications for stent placement in vascular access failure: acute angioplasty failure, rapid recurrence of lesion, and vessel rupture. But in the KDOQI guidelines, the work group confessed that they did not consult a comprehensive literature and data review of recent study to recommend angioplasty as the first choice of treatment. The series with the best outcomes for angioplasty are showing primary patency rates at 1 year of 20–30%, and that randomized the study with more than 100 of patients shows that elective PTA for lesions greater than 50% stenosis did not alter thrombosis rate and time to graft loss. In this prospective multicenter randomized study with almost 200 of patients, the incidence of patency of treatment area and access circuit was significantly higher for stent graft than for balloon angioplasty, with primary patency rates for angioplasty less than 20% at 6 months. In another area, in cephalic arch stenosis treated with PTA, we observed that the interval time between subsequent angioplasty decreases progressively. Then, what is that? An example of planned obsolescence in medicine? Is PTA really the first and the best choice of treatment? We will present 3 scenarios in which we feel that the use of covered stents are helpful to vascular access recovery. The first scenario is cephalic arch stenosis. Cephalic arch stenosis is a common cause of arteriovenous fistula failure with high resistance to treatment. Cephalic vein travels between pectoralis major and deltoid before piercing the coracoclavicular fascia and entry to the axillary vein just below the clavicle. Proposed etiologies are arterial flow in a fistulized cephalic vein that causes neointimal hyperplasia, external compression by fascia and pectoralis major, larger number of valves, morphology and angle of the cephalic vein entry into the axillary vein, and renal failure that causes endothelial dysfunction. In this example with an enlarged fistula, we found a cephalic arch stenosis with typical collateral flow to maintain patency. First, we use a floppy wire to cross the lesion. Then we change this wire. We use a terumo-stiff wire. It's a more rigid wire to correct the angle, but not excessively, to ensure accurate deployment of the stent graft. As you can see, a high-pressure balloon filled to overcome the lesion. We place a Viavan 850 mm in the cephalic arch, and after stent graft dilation, we obtain a good endobypass of 8 mm with more than 5 years of primary patency. This is a complete percutaneous technique, and we can use immediately this fistula. In 2008, a randomized study showed better results for stent graft treatment in terms of primary patency rates versus a standard bare metal stents. In theory, we have 2 reasons to believe that covered stents increases these patency rates. One, this device interposes a mechanical barrier between the vessel wall and the flowing blood, and it excludes areas of intimal hyperplasia. And two, it breaks the fibrous stenosis to achieve an appropriate diameter. In terms of controlled explosion, it breaks the fibrotic vein. Our results, with only 7 patients in our new hospital, with this technique confirm a primary patency of 100% at 6 months. This is a good procedure, in our opinion, to treat the most frequent stenosis in upper arm fistula. But we believe that it is useful to treat the most frequent type of stenosis in grafts, the graft-to-vein anastomotic stenosis. This is our second scenario. And two of the key issues here are that thrombosis for the diagnosis of stenosis is 3 times more often in grafts than in upper arm fistulas. And in recurrent failure of prosthetic grafts, stent graft placement improves significantly primary patency in prospective trial, as well as the study by Katsanos and collaborators shows. With clear difference, at 1 year, we can see the primary patency rate is 8% for PTA versus 61% for stent graft placement. For this condition with thrombosed graft, we follow a protocol. We make, to access recovery, we make a longitudinal incision to maintain the largest area of puncture scar-free, then thrombectomy of the arterial and venous sector. We make a fistulography, and frequently we found graft-to-vein stenosis, and we treat this with Bayama normally with good results. Why do covered stents potentially work better than PTA and other devices in this scenario? Because they exclude areas of pathology, intimal hyperplasia, aggressive fibrotic lesion, because the covering acts as a barrier for the further development of hyperplasia and immediate recall, because this exclusion is obtained non-traumatically as compared to surgery, without surgical manipulation and denudation of vessel, and less risk of rupture of future stenosis. This promotes laminar flow, whereas the end-to-side venous anastomosis was associated with more turbulent flow, and cannulation of stent graft is possible. It simply extends the PTFE graft. The third scenario are pseudoaneurysm in grafts. Early experience have demonstrated that the use of stent graft can successfully exclude pseudoaneurysm from hemodialysis grafts. Some technical and evolutive considerations are graft approach or percutaneous puncture in the apex of the loop graft. These allow access to arterial and venous sector in order to be able to treat pseudoaneurysm on both sides, but also the presence of a venous anastomotic stenosis that is common and may be responsible for the pseudoaneurysm. Use of a 7 mm diameter Viavan. The Viavan is constructed of tubular PTFE. Graft is a PTFE conduit, and looped graft is a 6 mm diameter. Recommended Viavan for this diameter then is 7 mm. Post-dilation with balloon to ensure complete apposition and exclusion of the pseudoaneurysm and prevent leaks. And in our experience, cannulation is possible, but with some delay, 4 weeks, because the blood contained between the pseudoaneurysm thrombosis and this thrombus undergo retraction and fibrosis, developing a protective fibrotic layer. To conclusion, we must go beyond the present stage in which angioplasty is considered gold standard or first choice of treatment. Gold is another thing. Stent grafts have demonstrated superior patency rates compared to angioplasty for selected endovascular indications. Next, crossing from the clinical experience to the answer, we need randomized controlled trials to test the efficacy of diverse procedures and cost-effectiveness analysis to choose the less expensive strategy to maintain patency. And finally, when considering this issue, we cannot be homogeneous and assume that every vascular access failure is equal. Different anatomical areas, different techniques, different devices, and covered stents mean different outcomes. Thank you very much.